Hello and welcome. Back in March of 2020, the BC chapter of the Canadian Association of Critical Care Nurses held their Spring Innovation Roundtable. This was one of the presentations shared at that event. Transforming critical care by implementing an electronic health record system across 3 health authorities. This presentation was presented by Martiza Dreger, critical care nurse and clinical informatics specialist. Apologies in advance. There were some technical difficulties during this event, and so the recording isn't quite as clear as we would hope it to be, but I do think you can still enjoy it. So without further ado, here's Martiza.
Context about what it is, as well as a little bit more information about how we implemented Cerner here at Providence Healthcare. I also wanted to share a little bit about my role and what I've been involved in as a clinical informatics specialist, or a CIS, as well as provide some lessons learned, reflections, and takeaways from being in the thick of sustainment. So what is CXT? CXT stands for Clinical and Systems Transformation. So the implementation of an electronic health record is nothing new. We've done that globally. It's happening all across North America. But this project is unique because it's the first in Canada that has incorporated the collaboration across 3 major health organizations. So these 3 health organizations included Vancouver Coastal Health, Providence Healthcare, Provincial Health Services Authority, and the 3 of these HOs decided that they were going to share one clinical information system. So I have embraced the word enterprise. So the CST project has done these HOs as enterprise. So when they talk about building for all these 3 HOs, enterprise is just a nicer, cooler way of incorporating all HOs. So it's a little bit of an easier kind of Cerner speak or project speak, if you will, but that's how we identify the 3 HOs, is by enterprise. So Cerner is the platform, the company that was chosen for this shared clinical information system. It's known globally around the world for implementing hundreds of electronic health systems around the world. And some of you may have heard of Cerner already. We have counterparts in BIHA that use a version of Cerner, as well as London Health in Ontario. They have their own version of Cerner, but it's all the same company. So the uniqueness of this project includes the 3 health organizations, like I mentioned. But it's a project that spans a number of years and is still ongoing as we speak. So the project roadmap itself is massive, and it incorporates different phases of when these sites and health organizations go live. And Vinny already mentioned that we went live here at Providence November of 2019. So we were the 2nd health organization, major site to go live with Cerner. The first organization to go live with Lionsgate Hospital over in the North Shore, along with sites over in Whistler, Pemberton, and Squamish. And there continues to be ongoing work now at the project level to prepare remaining sites for their go-live dates. So these include BC Cancer Facilities, BC Children's and Women's is slated to go live with Cerner, I believe, early 2021, and I think Vancouver General Hospital is slated to go live in 2021 as well. So lots of work to be done. So my role as a clinical informatics specialist is unique. It's a new position here at Providence Healthcare. It's kind of exciting because I kind of get to be part of like a new adventure, if you will. So as a member of this clinical informatics group, I also am a member of the project informatics team. So we essentially try our very hardest to translate clinical workflows, clinical data, translate all of that information into system build and design to transform how we clinicians can deliver patient care. So we are experts, if you will, in this system electronic world, and we try to bridge the electronic world with the clinical world and try to ensure that the 2 worlds can speak to each other. So I'm kind of that middle person. And being a site informatics specialist, I also am the middle person between the project as well as Providence Healthcare and the Clinical Care Program in regards to how I can best support projects down the site, and now that we've gone live, how can I continue to support Providence Healthcare and critical care? So I was involved heavily with implementation, preparing Providence Healthcare, the critical care program to adopt and turn Cerner on. And now that we have the system live, my shift has completely focused or shifted towards sustainment. So I wanted to share what critical care across the three AHOs, how were they involved in the project. So just a brief overview, the project itself is guided by 6 or 7 different key performance. So this helps everyone working in the project focus their design and build to ensure that there's the greatest positive patient care impacts. So where do we begin? So the project started off gathering information. So this included clinical documentation. Think of flow sheets, patient assessment records, order sets, all of that data, as well as understanding the day-to-day work of a critical care unit in all of these 3 different health organizations. So how do patients get admitted to our ICUs? How do they get transferred out? What does ongoing care look like? So all of that had to be broken down into pieces that could be understood and then translated and built into an electronic world. So we moved after things were gathered and data was gathered. We then encountered needing to meet with subject matter experts from critical care. So these include your nurse leaders, educators, nurse specialists, bedside nurses, and from all the data that was gathered, the project had to show what that looked like in the system. And these subject matter experts informed the design and build of what critical care looked like in the electronic world. And as you can imagine, collaborating across 3 health organizations required standardization and regionalization of information. How do we do things in the critical care world? Which is pretty exciting, really, to just share knowledge across and between our colleagues. So that was a very unique point, and it was very humbling to be a part and to experience and understand how different areas were working while we're all trying to provide patient care to good quality care to our patients. So moving from these design sessions, the project developed these groups called governance. So every specialty, such as critical care, cardiology, surgery, etc., had working groups. So membership to these groups encompassed and incorporated representation across all of the 3 health organizations, and membership was appointed by the respective HO's senior leadership teams. And again, these are experts in critical care. They are your nurse specialists. Vinny is a member of our critical care working group, as well as physician champions, nurse educators, nurse leaders, etc. And we would meet on a regular basis and continue to do so. And from these meetings, we would see the design and build that was discussed among subject matter experts. And within this meeting and this venue, we would be provided demonstrations by our counterparts at the project. And essentially, this group would have the final say of what critical care looked like in the patient's chart in the electronic world. So it's kind of exciting to have that kind of power, to be able to inform, this is what my electronic world would look like. So that's kind of the gist of the structure and how critical care was involved in design, build, implementation of the electronic version of our paper world. And then if there were ever any disagreements within this governance group, there was a fail-safe where decisions would be escalated within the project to senior leaderships, members, and ultimately to the CFO of the project to make final decisions. And occasionally that has happened. So hopefully that gives a little bit of context to the project and the structure for some that may not be familiar with the inner workings of implementing an electronic health record system. So I wanted to shift our focus now to sustainment. So leading up to Providence Healthcare's go-live date with Cerner in November, we had roughly about 2.5 months of time to really prepare all of our staff members. So we had, the project had developed an adoption plan, which included ensuring all of our clinicians were doing e-learning modules. There was mandatory in-classroom training time, as well as peer-to-peer workflow reviews. And so there were limitations and time restrictions on all of this. In hindsight now, after we've kind of gone live, it would have been nice to have that extra little bit of time. There were about 2 weeks prior to going live with the system where we had diversion, where patients were being diverted to different areas in different hospitals so that our patient volume overall was decreased so that our clinicians could get used or have the time to be able to learn the systems from their peers, to be able to play around in these play domains, if you will, and just to get a little bit of a better grasp on the electronic system. I also just wanted to provide a little bit of overview of what sustainment looks like from my perspective. So now that we're in sustainment, we use a platform called Jira, and you may or may not have heard of this before, but Jira is a platform where tickets, they're called tickets, but essentially any and all issues are tracked. And we have this help desk or service desk, which is the first line of support for all of our end users. And they've been directed to call this help desk, there's a number, and speak to an operator for troubleshooting, as well as communicating that there's been an issue encountered in the system. It could be anything. It could be a glitch that they've encountered. It could be an issue with the workflow. So from these issues, myself and my colleagues, we track these issues. They're given a severity level, depending on whether it's critical, impacting patient care, high, medium, low. And then we discuss on a daily basis what we can do about these issues at the local level. Do we have to provide education to end users? Is this something that needs to be pushed to the project so that they can look at perhaps modifying the build and design? So there's a lot of open communication between us here at the site with the project. So it's a lot of ongoing work, but it's kind of nice to be able to know that there is the opportunity to modify the build that government groups have decided upon. So we're seeing a lot of optimization requests of, can I modify the name of this? Or can I change something in a power plant, for example? I'll describe what a power plant is in a little bit, but I wanted to just provide some context to the sustainment structure that we have right now here at Providence Healthcare. So we're about 3.5 months, almost 4 months into sustainment. So what have we learned? So I've kind of just categorized 4 major things that I wanted to kind of talk to you guys all about and share. So the first one being change management, learning, and transition. So one of the biggest things that occurred when we turned the system on was a huge role change for our unit clerks. So pre-Cerner, we had unit clerks helping to process orders that providers would write down in a patient's chart. They would enter it into a system we had pre-Cerner called SCM, and they were an integral part of our critical care unit, as well as elsewhere in the hospital. So when we went live with Cerner, unit clerks were no longer able to put in orders into the system. So this is a huge shift in operational needs, as well as for the unit in terms of, what do I do now? What happens now? There's a lot of onus on the providers, as well as nurses and other clinicians that can do order entry, to do their order entry. And that was a huge shift for a lot of different users of the system. Another thing that I want to point out with this learning curve and transition was that all of our nurses were now on the same learning level. You had senior nurses who have 20 plus years of critical care experience now being brought back to their student years of being a novice. So it was a very humbling experience, very frustrating time for a lot of our nurses on the floor to then have to cope with this vulnerability, if you will, of being put back into this novice level. And then on top of that, we had teachers being learners, because as a teaching hospital at Providence Healthcare, we still had rotating nursing students come through during this time of go live, as well as a monthly rotation in new residents. So we had kind of the blind leading the blind for a little bit. And that was a huge challenge and another stressor on a program trying to learn a new system. We did have diversion, but that was lifted a couple weeks after we went live with the system. And then we had this learning curve with learning how to work with a workstation. So as you can see on my slide, I have a picture of a workstation on wheels, or they're publicly known as or cows, if you will. We use the term cows. So this is as close as a picture of a model of the workstation on wheels that we use currently here at Providence, specifically in the critical care areas. So how do you incorporate this into your day-to-day practice? So again, it was a shift of physically and ergonomically, how do I sit with it? How do I stand with it? How do I move with it? So this is essentially a computer on wheels, and there is a barcode scanner that is attached to help support closed-loop medication administration, keyboard. So this was obviously a huge change as well, because now we don't really have any paper charts. We do have like a chart light, because there's still certain key elements that remain on paper, such as consent forms. So there are that we have with these that company workstations. But again, it's like, how do I use this and incorporate this into my clinical practice? So that was a huge change for a lot of our clinicians. And the idea of not knowing what you don't know, and is it an end user knowledge gap, or is it a glitch in the system? So that was a huge challenge for a lot of our clinicians in the first month. And I saw a lot of Jira tickets coming through about end user errors as well as glitches. And that was a challenge for us too, because I claim to be an expert, I try to be an expert, but there's still a lot of things about the Cerner system that I don't know and I'm continually learning about. So it was a very challenging time. I think that we've kind of come to a nice plateau now, where I feel a lot of our clinicians are feeling a little bit more comfortable using the system, using a workstation. But we still have challenges as well. So still lots of learning, still lots of education are being done. I also wanted to speak to everyone about critical care rounds. So it was a little bit interesting the first day that we went live with Cerner, and we had to do rounds as an interdisciplinary team. If you can imagine, 6 different of these workstations were wheeled together into a circle, and everyone just looked at each other and didn't know what to do. It was almost like rounds, which is something that we normally can easily do and breeze through, became this unknown. It's almost like we needed a script. Like everyone had to play a role and it needed to be scripted. So comical in hindsight, but definitely scary if you were involved in the first rounds in critical care with like Cerner. But luckily we were privileged to have a provider from London HealthCom volunteer his time for about 4 weeks and be a provider support for our team. And he was able to share insight on how he was able to conduct rounds over in his hospital, and then it got a little bit easier. But it's still challenging because every position, be it a nurse, a provider, an RT, they have a slightly different perspective of the patient's chart when they're logged into the system. And as streamlined as the electronic health record tries to be, there's a lot of information that can be viewed, and there is no central place for all this information. So it was a challenge to identify, where am I getting this information to tell the story I need to tell about my patient in rounds. So that also compounded the challenge of rounds that our teams experienced in the first couple of weeks. But it's gotten a lot better, and our unit has decided that we would limit the number of workstations we would incorporate into rounds. So I believe it's down to about 3 or 4. It's also just to ensure there's no safety and physical hazards in the hallways, especially with patient movement, x-ray machines coming up and down the hallways, etc. But I think it was just comical to see blank stares and senior residents not knowing what they were doing, and nurses just being like, I don't know what to do. And I think one of the takeaways from that would be we probably should have done a simulation. Probably should have gotten key players together into a room with these workstations in a train domain and really just played out what rounds was going to look like and who was going to do what. So some nice takeaways for our colleagues that have yet to go live with Cerner, and hopefully they'll incorporate that into their adoption plan. The other topic I wanted to speak to is communication. So this is a little broad, but what we've learned and what I've observed is that now that we have Cerner, a lot of clinicians don't really talk to one another anymore. So they've seen Cerner being used as a replacement for communicating key messages about patient care. So that has been a consistent observation, not just in critical care, but across all different departments in the hospital, where a provider would feel that he or she has placed an order in the system, and sometimes that extra added verbal communication to one another is lacking. So that's a key thing to just kind of highlight that, Cerner is wonderful, it's electronic, it's allowing end users to see information in real time, but there still needs to be that, face-to-face conversation or phone call. The other thing that Cerner, about communication with Cerner was that everyone had to shift and learn these new definitions. What does a consult mean in Cerner? So pre-Cerner, in the paper world, Providence Healthcare used consults and referrals interchangeably. But once we went live with Cerner, consults were defined as specifically for inpatients, and referrals were for patients when they're discharged, required to see someone when they're an outpatient. So that was a little bit of a shift. And then another example of this kind of Cerner lingo that we had to learn was encounters. So patients have encounters created in the system, and there are a variety of different encounters depending on the type of patient's clinical needs. So wrapping our heads around what an encounter is, and then also the ideas about transfers and discharges. Cerner is built a different way than how you would communicate a transfer and discharge. So communication in that respect is a little bit of a challenge. And being in my role, I had to be mindful of how I spoke to my colleagues and peers, because I would be dropping CST lingo words like DTA and ESHs and so forth, and then I had to take a step back because I realized that my colleagues had no idea what I was talking about. So there's a level now of being mindful of this electronic world, if you will, and trying to tie it into the clinical world. And maybe Vinny could maybe mention a brief portion of this, but now that we are users of Cerner, we're seen as experts. And in these governance groups that we continue to have, I'm sure it's informed your decision making about Cerner build and design in a different way, and it probably changes how you speak to your decisions and how it might impact your colleagues in these online sites. So I don't know if you want to take a moment to kind of speak to that.
Sure. I mean, I think when we were in the design phase, and it was years in the making.
Yeah.
When we were in the design phase, we were imagining what this system looked like and what it did, and so we made decisions based on what we imagined. And some of those decisions were great, and some of them were not. So when you actually have it in a live system, you're like, oh, that's not going to work out so well. So having a live system and having experience with it, now we have much better understanding of. So we have, I think, a little bit more knowledge to make those decisions with. And so, it is pretty cool to say, yeah, that's not going to work, and this is why. Whereas before, we were like not so certain about that.
So I think in some ways it kind of helps the sharing of information across these partnerships that we form with our colleagues in different health organizations. So I think it's a wonderful thing to be able to speak to having used the system to inform, future design and build for the upcoming sites. And then the other thing I just wanted to point out that challenge, in addition to all of this kind of Cerner lingo, is the terminology that we're using to describe aspects of the patient's charts. So for an example I wanted to provide is that in paper we had order sets. in the Cerner world are called power plans, and then embedded within these power plans are mini order sets called modules. So just trying to wrap our brains around this lingo has also been a challenge. And what's also been available within ordering these power plans are multi-phase power plans. So what these are order sets that are broken up into different phases that can be activated independent of one another. So that concept is foreign to a lot of clinicians, and it continues to be a challenge for providers when they're ordering and activating these multi-phase power plans in addition to our nurses. So again, those are just some of the challenges that we've encountered that still require a lot more site and user education. The one amazing positive that has come out of these 3 months of going live with Cerner has been with our critical care outreach team. I know Vinny's really excited because she's pulled data. So it's exciting because we have a tool and we're still learning about what we can use from the electronic system, but one of the key things is when we know the questions to ask, the data we pull can really inform quality improvement and innovation within critical care, and specifically for our units now. So I just wanted to share a couple of slides that Vinny has kindly allowed me to share about some of the outcomes of using Cerner and how that impacts our critical care outcomes.
Actually, if I may,
yes,
just so for everyone who knows, so we implemented a critical care outreach team in February of last year, so we're just a year old. And when we implemented, what we wanted to do is we knew Cerner was coming, so we gave all our team computers, we gave them a fillable PDF form rather than a paper form, so they would just get used to having fingers on keys as much as possible. And they took this computer to each bedside, they did their head-to-toe assessment, they filled out the form there, they printed a copy and they saved a copy for me that I was able to gather data from. So we would have real-time data about how we were doing as we were evolving our system. And then when we converted to Cerner, we went back into the CACCN database, so that's where all our data lives. So this is, what you're seeing here is all of the CACCN data from the time that we began existing. Yeah, you want me to tell you the slide?
Yeah, I'll try my best to interpret your data. Please feel free to jump in. So I think the biggest thing to note from this slide is that we're capturing data about CACCN response times, and it's the initial contact. But I want you guys to focus on the last bar on the right, which is the fourth quarter in 2019/2020. And we have significantly seen a decrease in how fast we are responding to these initial CACCN calls. So we are kind of within more of the 15 to 30 minutes, and we also have been able to decrease the number of calls with missing data. So I think in the paper world, sometimes it was really challenging to track when a CACCN nurse would have arrived onto the unit to speak to a patient and then capturing that. So I'm just comparing the bar quarter 3 of the gray of 22, and then quarter 4, we're down to 3. So I think that's a huge significant data piece to just be mindful of. And this is only 3 months into a live electronic system. And
they're all still very new with the system. So what it is, we try to be at the bedside within 5 minutes, and we are for a good chunk of the time, but we're not always there within 5 minutes. 5 to 15 is the green. So we want the green to be around 90%. And we haven't quite achieved that. We were close for most of them. We were in the 70% range for the previous quarters. We went live halfway through quarter 3 of 2019/2020. And so you see that big jump in our response times. Now, this is actually probably more related to the next slide.
Oh, yeah.
So why are we suddenly faster? I think this is why we're faster. This is our distribution of duration. So within 60 minutes is the blue. So up to green and blue, that's within 60 minutes. You can see that prior to 80% of the time we spent about 60 minutes at the bedside, usually for new calls. But you can see there's a good chunk of times that we were spending more than 60 minutes at bedside, sometimes as much as 2.5 hours or more, depending on what was going on the unit. Why are we far more efficient? Well, when you talk to our CCOT teams, there's a couple of reasons. Before Cerner, when we were getting handover from the last time the nurse had seen that patient. Post Cerner, we're now getting handover from the last set of vital signs that were documented in the chart, regardless of where they are. So you're able to get a much more detailed report in handover. When you show up at the bedside, you know exactly what's been going on, and you can triage who you need to see first. The other thing is when you're at the bedside, you don't have to fight for the chart. You don't have to find the chart. It is there at your fingertips. So that has created a lot more efficiency in being able to manage patients. We're not hunting for the chart. We don't have to hunt for this. Everyone can access it at the same time, and we can do our work more quickly. So our duration of time at each bedside has become far more shorter, and we're much more efficient, which means we are now available to respond to the next call much sooner as well. So I think this really speaks to, you manage CCOT workload, and suddenly the response rate goes up.
Yeah, the only other point I wanted to highlight was that as a CCOT nurse, if they're receiving a call from a nurse on the ward, they can look at the chart simultaneously and view data together. So I think that's also contributed to these decreased duration times, as well as how quickly the CCOT team members have been able to respond to their initial calls and with their follow-up visits and so forth. So I think that's a very powerful aspect of a shared information system. Clinicians can view information in real time. And again, the key thing is that they're not looking through papers and trying to hunt down a chart. I can't tell you how many times I've been frustrated as a nurse trying to find a paper, the patient's chart, only to have it sit somewhere in the back room. I think this is very encouraging because it shows the power of how we can pull data to improve and guide quality improvement initiatives, and how we can inform how we deliver critical care to our patients here, as well as within our critical care outreach team. And another thing I wanted to speak to about the power of collaboration is that we standardize the build and design. So it's the same build and design that BGH will use for their robust critical care outreach team, and Lionsgate, who before had no critical care outreach team, is now looking in creating one and implementing it very soon. So there is a foundation there of information design and build that can drive local projects and improve quality at the local site level. So I think it's very powerful just to have that collaboration piece that was so integral to this huge project of implementing a shared information system across 3 HOs. I think we're still very young as a site in using this electronic health record. I think there's still lots to learn, but I think we're at a stage now where we can say that we feel a little bit more comfortable. We're still managing issues, and there's still challenges with clinicians and across our nurses and providers and how we continue to provide quality care. But I believe the overall sense from our staff here in our unit has been a relatively positive one in using Cerner. So it makes my work exciting, it makes Vinny's work exciting, and then the work here in our critical care unit exciting, and hopefully by sharing some of our experiences, it probably encourages you to seek out maybe implementing your own electronic health system in your HO. But exciting times ahead for sure. I think we're finally getting with the times. So pretty much my presentation. I do apologize. I have to early, so if there are any questions, if you can send them to Vinny, I'd be happy to answer them later. Back to you all. So thank you very much, everyone.
Thanks for watching, everyone, and thank you for joining us on the BC chapter of the CACCN YouTube channel. We have a lot of great content from previous events we've had over the past 12 months. I would suggest subscribe and hit the notification button so you can know when the next thing is out. And if you ever want to come to our next event, we're on Facebook and on Instagram. Our links are listed below. And while I'm on the topic, if you're a critical care nurse anywhere in Canada, why don't you join CACCN? We have a ton of resources to help you be the best critical care nurse you can be. Go to caccn.ca and join us.